Good morning, and thank you for joining the RLS Foundation's webinar titled Basics of RLS. My name is Zibby Crawford. I'm the Marketing Coordinator at the Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Burkowski will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the webinar recording. The recording will also be made available in the member portal section of our website. If you are not a Foundation member, and if you'd like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for information purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Andrew Burkowski. He's an assistant professor at the University of Michigan and an expert in RLS. He cares for patients in the Sleep Disorders Center in Ann Arbor, Michigan, addressing a wide range of sleep disorders in adults. Before receiving board certification in sleep medicine and neurology, Dr. Burkowski earned his bachelor's degree in religious studies at Stanford University. Next, he returned to his home state of Michigan to study medicine, graduating from Wayne State University School of Medicine. He completed a transitional year internship at Henry Ford Hospital and neurology residency training at the Detroit Medical Center, Wayne State University. Dr. Burkowski completed his fellowship training in sleep medicine at the Stanford University Medical Center. He serves as a member of the American Academy of Sleep Medicine's task force for the 2021 clinical guidelines for the management of RLS, and recently joined the RLS Foundation's Scientific and Medical Advisory Board. Dr. Burkowski, we thank you for sharing your time and your expertise with us today. I now invite you to begin the presentation.
Thank you so much, Zibby, for that introduction. So let me just move on to my first slide here, if it will let me. There it goes. So this is Sir Thomas Willis. He's the English physician who is thought to have first described restless leg syndrome. It's actually too bad this isn't a video webinar, because this is exactly what I'm wearing right now. In fact, well, except for the lipstick, but my 9 a.m. patient this morning, it really threw him for a loop when I showed up in this costume. Now, Zibby may not have mentioned this in the introduction, but I really have an extensive background in voice acting, including this one time in 12th grade. I had to take part in this 5-minute scene from Shakespeare, and I developed this British English accent. So here goes. Wherefore to some, when being abed, they betake themselves to sleep, presently in the arms and legs, leapings and contractions of the tendons, and so great a restlessness and tossings of their members ensue, that the diseased are no more able to sleep than if they were in the place of greatest torture. Now, with that aside, I would like to say I have no disclosures or conflicts of interest. I'd also like to point out that neither the RLS Foundation nor its Scientific and Medical Advisory Board has influenced or edited this webinar, other than giving me the title. So I'm speaking quite freely today. And I would also point out that some of the recommendations and conclusions are not yet evidence-based and may reflect my opinion, which is based on my clinical experience. And it may not actually be consistent with some of the members and the practices of the RLS Foundation and its scientific experts. So there are 3 important points. If you forget everything, including the British accent, there are 3 important points I want you to know about restless legs syndrome. Number 1, restless leg syndrome is a brain disease that involves iron. Number 2, before you think about medications for restless leg syndrome, be aware that lifestyle improvement, nutrition, sleep, etc., should be the most important part of relieving restless legs symptoms. And also keep in mind, we don't know that restless legs needs to be treated if it's not that bothersome. And number 3, if you remember, dopamine agonists, abbreviated DA, DA stands for dangerous. So be careful when you take dopamine agonists. So let me go through the outline as to what this webinar will cover. First, we're going to talk about what exactly is restless leg syndrome. Then the significance of a related phenomenon called periodic limb movements. And then we're going to get into more detail about the role of iron and dopamine in restless leg syndrome. And then we'll move on to different types of lifestyle modifications that may help with symptoms. From that point, we'll talk more about medications, particularly the problems with the aforementioned dopamine agonists, and then also the main medications that I recommend for pharmacological and otherwise for treatment of the condition. So restless leg syndrome is also known as Willis-Ekbom disease. It's often abbreviated RLS or RLS/WED. And Willis-Ekbom disease came about later on because of a thought that giving a title to the condition rather than a syndrome and calling it a disease would help people and physicians even to take the condition more seriously. So as I mentioned, Sir Thomas Willis was the first one who probably described restless leg syndrome. And then Carl Axel Ekbom was an early 20th century Swedish neurologist who was thought to first coin the term restless leg syndrome. And I love the term restless leg syndrome because it's exactly what the condition is. And most patients describe restless leg syndrome as this restless feeling, and it's a great description. So we just had the State of the Union address this week, so I'm going to say the State of the Union of restless legs in Western medicine. And unfortunately, restless leg syndrome has been considered, even recently, as little as 20, 25 years ago, by many doctors to be a made-up condition, which is very disturbing. Many physicians currently feel the condition is minor. If you see your primary care doctor, it might be the 8th thing that they care about on the list of conditions, and maybe because it's not going to kill you, but it really can be disruptive to life. If you saw the patients that I see, most of them can't work, most of them can't sleep well, many of them have been forced into retirement. It can be a very devastating condition, and it's not a minor condition at all. And there seems to be a lack of awareness, maybe stemming from the lack of thought that it's a serious condition, but physicians and providers do not seem to keep up with recent clinical advances in clinical management, which is a problem. So I want to emphasize that you may actually know more than your doctor, and it's great the work the Restless Leg Syndrome Foundation is providing. I encourage you to look at all the resources on the website, because these are things your doctor might not be looking at. And you must advocate for yourself, because this is not a condition that is taken very seriously by physicians. And so you have to support yourself, and you can't allow yourself to be managed inappropriately, because there's a lot of rabbit holes you don't want to go down. So what is restless leg syndrome? Well, it's actually a disorder mainly of the brain. So it's mostly not in the legs themselves, but it's in the parts of the brain that actually feel what's going on in the legs. Although there are parts of the legs and the spinal cord that are involved, it's mainly a brain disorder. And fundamentally, as I mentioned, the word restlessness, there's this urge to move the legs. So that's really hallmark to the condition. So the International Restless Leg Syndrome Study Group is a prominent group that gets together once or twice a year. And they developed, many years ago, they developed a diagnostic criteria that was recently reformatted. And it consists of 5 items. So number 1 is the fundamental urge to move the legs. Second is that there's a cyclic pattern throughout the day of restless legs. For most individuals, the symptoms should be only occurring at nighttime, or at least worse at night than at other times of the day. And then the condition should be worsened by rest. So by not moving the legs, it should actually make the symptoms worse when you have them. And then when you move the legs, it should feel more comfortable to move them than to keep them at rest. And then the 5th criteria is that if you have another condition, restless leg syndrome would be separate, that it can't solely be explained for by one of these other conditions. So another point of emphasis I would say is that restless leg syndrome can only be diagnosed by your healthcare provider based on your symptoms. There is no test, no blood test, no diagnostic test that can diagnose the condition. It's based on the clinical judgment of the provider and by what you tell the provider. So if anybody said that they have a test for it, there are tests that help restless legs, but there are no tests to diagnose the condition definitively. So a couple interesting facts about restless legs, the most important ones in particular. So there is a world prevalence, a lot of different estimates depending on how you diagnose the condition, but it's somewhere between 5 to 14.3% of the population according to these criteria. So that's a huge number of people in the world with restless legs, and about half of all these people have significant symptoms. Maybe some people have symptoms and it doesn't bother them, but they notice it. But 50% or so have symptoms that really affect their day-to-day function. And it is definitely, it's a genetically related condition, and it may be more common in European and Caucasian North American ancestry compared to other regions of the world like Asia or Africa, or people who have descended from those populations. Women are twice as likely to have restless leg syndrome than men, and pregnant women, about 20% will experience restless legs during the pregnancy. So 1 out of every 5 women who are pregnant know what it's like to have restless leg syndrome. And restless leg syndrome increases with age, although the condition doesn't necessarily get worse. So it's not inevitable that the restless legs get worse. It's just more common with age because more health problems crop up as you age. So what are some of the effects that restless legs causes on day-to-day function? Well, there is a discomfort while lying down or trying to sleep. So that can be quite a problem. Most people with restless leg syndrome don't tolerate sedentary activities. So the worst ones are going to the theater and sitting in a confined space, or the worst one, which is going on an airplane where you're basically in a box and you can't move and there's low oxygen in the air from flying at high altitude. And then it can affect these symptoms can affect one's mood, including feeling angry, frustrated, irritable, or even anxious about, hey, I've got to take an 8-hour flight to Europe. What am I going to do? My legs are going to be going nuts. So these are all symptoms that people have with restless legs. And then some of the ones related to sleep, it's difficulty falling asleep, or if you wake up during the night, the legs bother you, so it's hard to lie down and go back to sleep at times. And then just the fact that you can't sit there, you have to sometimes get up and move around. You've always got to be on one's feet. So these are some of the main effects of restless legs on day-to-day function. So there are other conditions that may have similar symptoms to restless legs that you have to distinguish, or the provider has to distinguish. And one common one is just these leg muscle cramps that people get often at nighttime, but this is more of a pulling of the muscle or a cramping of the muscle. It's very distinct from restless legs. There could be pain and discomfort just from not moving your legs. If you sit too still, the body's always meant to be moving. When you sleep, your body rotates and moves around naturally. Your joints can start to hurt if you don't move for a very long time. That's not restless legs. And then there are conditions like neuropathy, people with diabetes who have numbness, tingling, and burning in their feet. This is not restless legs, but it can be confused with restless legs. And then people can just be restless. There could just be a general restlessness or fidgetiness, which is sometimes blamed for in children, and this is distinct. And then conditions such as attention deficit hyperactivity disorder as well. So I mentioned that I'm a voice actor. I do British voices, but I'm also a world-class graphic designer. And as you see, I spent months on this, and this is a tangent. So we're going to go off on a tangent right now. So I sometimes have patients come in and they say, well, my doctor told me my sleep study showed that I have restless leg syndrome. So this is false. What the sleep study showed probably was periodic limb movements in sleep, which is not the same thing as restless leg syndrome. So what are periodic limb movements in sleep, abbreviated PLMS? Well, so this is what we would see as a sleep doctor who's interpreting an overnight sleep study. I'm not going to bore you with all these squiggly lines, but this is a 5-minute recording, and these little bursts of red here, these are actually electrodes placed on the lower legs of the patient here. And every time you see these firings, this is when the leg is actually moving. And they're all about 20 or 30 seconds apart in this picture. So this is what we see when we're reading a sleep study. So what it really is a withdrawal movement of one or both legs. I would equate it to you're at the pool and it's hot outside and you get out of the pool and you step on the hot cement and your foot pulls up. That's sort of the movement of periodic limb movements, but it can be different for various individuals. Bed partners tend to describe a jerking or kicking movement with these. They tend to occur in a variable fashion, but every 20 to 40 seconds or so, and they may be present inconsistently. So they're usually present in the first third of the night, but they can happen all throughout the night, or even some nights you may not have them at all, and then other nights you do have them. So it's pretty inconsistent. So here are the important points. Most people with restless leg syndrome have periodic limb movements in sleep. However, most people with periodic limb movements in sleep do not have restless legs. So that's sort of a riddle, but that's one way to think about it. So one study showed that up to about 90, if you did multiple sleep studies on patients, up to 90% of people with restless leg syndrome may have periodic limb movements in sleep. There also have been studies showing that 45% of adults over the age of 65 have periodic limb movements of sleep. So as you get older, you're more likely to develop these limb movements, but that doesn't mean you're developing restless legs. And they're also seen in other conditions: heart failure, chronic kidney disease, spinal cord injury. So periodic limb movements of sleep will support a diagnosis of restless leg syndrome, but I want to be clear that periodic limb movements in sleep are neither necessary nor sufficient for the diagnosis. So what exactly causes restless leg syndrome? Well, as I mentioned, there's some disparities between different races and ethnic backgrounds, but these are due to genetic factors. So there are several genes that are involved in restless leg syndrome. You can't just inherit a gene and get it, but there are some genes that you could get that put you at higher risk. The two most important ones right now are MYZ1 and BTBD9. And so we know that low iron in the brain or poorly transported iron to certain areas of the brain seem to cause restless leg syndrome. And then there's a role with the sensations, because restless leg syndrome is actually a sensation that's occurring, that's generated in your brain for the areas of your legs or other parts of the body. And people with restless leg syndrome tend to have some defects in the sensations that are occurring in the brain. And then there's, of course, a dysfunction of dopamine connections, so the wiring of the brain revolving a chemical called dopamine. So what is the role of dopamine in restless leg syndrome? Well, there's a lot of factors involved. Originally, people discovered dopamine in restless legs as these dopamine drugs that affected dopamine tended to actually improve symptoms of restless legs. And I will point out, I will say at first, not if you take these drugs for a very long time, and we'll get to that. Iron also has a strong relationship to dopamine as well. The aforementioned BTBD9 gene, it's involved in dopamine and iron regulation in the brain. And so this is, again, my graphics design skills are coming through, as you can see. So I like to use the analogy of a shipping port. So right here, this is the space between one brain cell and the other, called the synapse. And one brain cell dumps out a bunch of dopamine, and the dopamine is like the package that's being delivered to the shipping port. And the shipping ports are on another brain cell, and when the dopamine package is delivered to the shipping port, it creates a signal, whether it's to relieve sensation or to actually cause sensation or something else, to have a thought, to move your leg. So this is basically how dopamine may work in the brain. Now, in restless leg syndrome, as you can see, if we go back to this one, these are normal shipping ports. Well, these have different shapes. There might not be the same structure. The dopamine may not fit quite as well. So basically, the shipping ports are a little bit dysfunctional. And that's kind of a simplistic way of thinking about it, but it really describes what's going on with dopamine in restless leg syndrome. So what is the role of iron in restless leg syndrome? Well, people with conditions that cause low iron are more likely to have restless leg syndrome. We do note that it's very controversial because there's a lot of variability with iron, but iron actually goes through cycles throughout the day and night. And iron in the blood or serum drops, in one study, dropped 30 to 50% at nighttime. And this correlates directly with when patients have symptoms. When the iron levels drop, particularly when iron is taken out of the brain, that's when the symptoms develop. And that's why restless legs occurs at nighttime compared to other times of the day. Iron is involved in making and transporting dopamine in the brain. So there's that kind of dual relationship between iron and dopamine. And then BTBD9 and MYZ1, these two genes, are also involved with iron metabolism in clinical studies of animals and of humans. There have been MRI studies. In one study, it showed lower levels of iron in the substantia nigra. That's a part of the brain where dopamine is manufactured by the brain. And people had lower dopamine if they had restless legs compared to without restless legs. And there are lower levels of ferritin. Ferritin is the storage form of iron, and it's low in the brain and spinal fluid of people with restless legs compared to people without restless legs. So this diagram, I don't want to show too many diagrams today, not to confuse people, but this is taken right out of a journal article by Dr. Early's group. Dr. Early will be doing the webinar next month. Cheap shout out to him and his webinar. But in this study, the control group is this line, meaning the people without restless leg syndrome, and then the people with restless legs is this line. So as the blood levels of iron go up or ferritin go up, the levels in the brain should go up. So this is the normal brain. The iron levels are going up proportionally to the blood levels. But if you notice for restless leg syndrome, first of all, the iron levels in the brain are much lower, even though the levels in the blood are the same. And then as the blood levels increase, the brain levels do not increase as fast. And this is really key to the understanding of restless leg syndrome, is that the iron levels in the brain are different when you have restless leg syndrome. So what are the blood tests for iron? Ferritin is extremely important. I want to point out that we think that the target should be greater than 75. So if you get your ferritin checked, it's going to show something like, oh, 12 to 200 is normal range. Well, that's not true for restless leg syndrome. Your ferritin needs to be at least 75. In some individuals, each individual is different. So some people may need 100, 125, 150 to feel their restless leg symptoms relieved. There's a second iron measure, which is the iron level divided by the total iron binding capacity. It's also called transferrin saturation, and this level should be above 20%. And it's important to check this while fasting. You don't want to eat a lot of iron or take an iron supplement and then check your blood levels, because that can throw off the transferrin saturation. It should also be done in the morning, because as I mentioned, the blood levels are really low throughout the night, and then they start to rise in the morning. So getting the blood tested first thing in the morning is the best idea, because if you get it checked at noon, your levels are going to be much higher than at night. So you might miss the fact that they're low because you're checking them when they're high. So the timing of when you do your blood test does matter. Do not take the iron supplement before. Don't take a vitamin that contains iron, and probably you shouldn't eat red meat, and we'll talk about red meat and iron in a second. And sometimes your doctor will do a complete blood count, which tells you your blood levels of hemoglobin. And hemoglobin is might be low, and that would tell your doctor that you're anemic and you may have low iron levels. So the management of restless leg syndrome. And so what do you do if you have it? So one of the things would be to address what activities affect restless leg syndrome. So what may worsen restless leg syndrome? Well, we had just mentioned, by definition, it gets worse with inactivity. So sitting makes things worse. Lying down might even be worse than sitting. But inactivity throughout the course of the day may make people more prone to restless leg syndrome at night. So there's also this paradoxical effect that we've observed, in that some people who do a lot of vigorous activity during the day may also have more restless legs. Like somebody goes for a 15-mile bike ride, they might have more restless legs that night than if they had just been sitting around all day. And I'm not encouraging people to not do vigorous activity, but just know that that has been observed. That could be a factor in symptoms. And then all of our vices, alcohol, caffeine, nicotine, tend to worsen restless legs. So what may improve restless legs? Well, there's some sort of sweet spot with movement. So moderate activity throughout the day, brisk walks, using a standing desk, things like that may be helpful for restless legs. Warm baths are very good. Warm baths before bedtime are excellent for sleep quality, but also excellent for relieving symptoms of restless legs. And also leg massage. And I was given this idea by Dr. Michelle Jo Nellis, who I trained with, and she came up with the idea of the foam roller to actually massage the legs prior to bedtime to give some sensations to the legs to help shut off the experience of restless legs. So stretching, including yoga, may also be helpful, particularly prior to bedtime. So let's talk a little bit about sleep in restless legs, because it's really important. Sleep hygiene is important for everyone, but people with poor sleep hygiene with restless legs, it tends to make the restless legs worse. Another important point, just statistically, there are so many people with a condition called obstructive sleep apnea. So identifying that you have the condition and treating it actually improves restless leg syndrome indirectly. And then if you have chronic insomnia where you have difficulty falling asleep or staying asleep, that happens on most nights, it's good to see a sleep physician. And there's a treatment called cognitive and behavioral therapy for insomnia, which tends to work a lot better than any of the medications that we know of for helping sleep. But addressing insomnia with a sleep physician ideally is a good indirect way to improve restless leg syndrome. So let me touch on the obstructive sleep apnea. In short, it's a mechanical problem of the throat. You've heard it before because you've probably heard somebody snore, but anybody who snores may have restless or it may have obstructive sleep apnea. The throat collapses and that causes the brain to wake up from sleep. And even worse, it causes the body to have intermittently low levels of oxygen, which is not good for restless legs as well as good for anything, including the blood vessels of the body. Treatment of obstructive sleep apnea indirectly improves restless leg syndrome. You don't even treat the restless legs, you just treat the sleep apnea. The restless legs gets better. And why is that? Well, it may be improving the sleep quality itself. The brain might be waking up fewer times during the night. And treating sleep apnea reduces inflammation in the body, and it also improves oxygen levels. And these are all factors that worsen restless legs. So here are the tips for sleep hygiene. The Restless Legs Syndrome Foundation will make my slides available after the webinar, but I'm not going to go over all these, but these are your basic tips for sleep hygiene if you want to look over these. These are the ones I found to be most important for restless legs, but these are just generally good things for everyone to adhere to. And then there's a case of inflammation. So inflammation is caused by a lot of different things. The ones that in America that we have the most trouble with are ones related to our dietary intake. So if we eat a lot of processed carbohydrates, processed foods, lots of sugar, this increases our blood sugar level. If we have increased blood sugar, it increases our insulin level that's released by our body. And it also could make us obese. So all of these things increase inflammation. And not to mention certain foods irritate the gut and can cause inflammation there. So these are all aspects in worsening restless leg syndrome. So let's touch on inflammation and restless legs. So if you have inflammation in your gastrointestinal system, in your gut, it can actually lead to poor absorption of iron. So your iron levels will become lower. But even on top of that, inflammation throughout the body can cause inflammation in the brain. And this can affect iron transport throughout the brain. So there could be areas of the brain that don't get enough iron because of this. And people with restless leg syndrome are more sensitive to low iron levels. So this is again, my graphic design, sad face. Most lifestyles, there's a lot of debates as to what's the best diet people should eat, but most lifestyles are going to be better than the sad standard American diet. So what are some of the important ones? Well, I want to point out the ketogenic diet. And this is a diet where you eat almost exclusively fat, you eat very little carbohydrate. It's used for many different conditions. It's highly anti-inflammatory. But when you're on a ketogenic diet, it does produce a chemical called beta-hydroxybutyrate. And there's been studies in brain metabolism where the iron transport is improved with beta-hydroxybutyrate. So there might be something special about the ketogenic diet with restless leg syndrome. Studies are not out there yet, but that's one of these potential things to study. And then you've got all of your diets that you've heard of: paleo, Atkins, South Beach, Mediterranean, Whole30. These are all fine diets. But the one I want to just simplify things and say, just eat whole foods, eat real foods. And what do I mean by that? Well, you could eat plants, you could eat animals that eat plants, but don't eat food made in a plant. So if you just remember these three things, it's a good way to eat whole foods, eat real foods. And that would really improve your lifestyle if you just did those things. So what are dietary sources of iron? It's important to get iron through your diet. So the best sources of iron come from animals, and I guess fish, but in terms of animals, red meat in particular. The liver is the biggest source of iron. Liver is where animals store iron. So if you eat liver, you're basically eating a lot of iron. So chicken liver is high up on the list. And then things like, remember, animals that eat plants, so grass-fed beef, dark turkey. Why is the meat dark? Well, the meat has more iron in it. So iron is a red element. It turns rust is red. So things that are red tend to have more iron. White meat has less iron than dark meat. And then for those of you who don't eat meat, you have your work cut out for you. You may need to find sources of iron. The plant material do not have what's called heme iron, so it's not as easily absorbed. I cross these out because I don't want you to eat processed food like oats or Wheat Bix or anything like that. But these other ones are good sources of iron. And then it's good to eat foods that have vitamin C because vitamin C helps to absorb iron. So eat your broccoli, eat your steak and broccoli, or eat your lentils with red peppers in them. So in terms of iron absorption, you may not get enough iron through your diet, but even if you do, you could have a condition that makes it difficult to get iron into your system. So there is a condition called small intestinal bacterial overgrowth, or SIBO, and recent studies have been starting to show that upwards of 40%, 50% of people with this condition develop restless leg syndrome. So there's a huge connection there. This condition is treated with antibiotics. Many of you may have heard of celiac disease, which is an autoimmune disease where the body attacks itself in response to exposure to gluten, which is a wheat protein, but gluten can be found in other things than wheat. And then there's non-celiac gluten sensitivity, which is not an autoimmune condition, but it's where you eat gluten and your body just goes crazy and you become very inflamed from exposure to the gluten. And then there are conditions that cause bleeding problems like ulcers, where you lose blood and lose iron. And then inflammatory conditions, Crohn's disease, ulcerative colitis can cause low levels of iron. And then bariatric surgery. If you have a bypass surgery, it's going to be hard for you to absorb iron. Part of the bariatric surgery so you don't absorb calories. Well, you're also not going to absorb nutrients, including iron. So you may need lifelong iron supplementation if you've had bariatric surgery. So other medical conditions, pregnancy, not a medical condition, really a medical situation. This is a good situation, but pregnancy can be a risk for low iron. Chronic kidney disease, or if you're on hemodialysis, you likely will have low iron. People who have cancer, because the iron is used by cancer cells and the body might try to keep the iron away from the cancer cells. There's more inflammation with cancer. And then chemotherapy damages the bone marrow, and you could lose a lot of iron through the side effects of chemotherapy and side effects on the blood cells. And then women who have heavy or irregular menstrual cycles may lose a lot of blood and lose a lot of iron during their periods. So what are the drugs that may worsen restless leg syndrome? So it might not be something you're doing with your lifestyle, but it might be actually a medication you're taking. So it's all the anti-drugs, we say. So anti-nausea drugs, antidepressants, including trazodone, which is used a lot for sleep. There's one antidepressant to remember, and that's bupropion or Wellbutrin. This one has some friendly dopamine properties, so it tends to not worsen restless legs, but all other antidepressants may worsen restless legs. And then your antihistamines, the older antihistamines, the diphenhydramine or Benadryl, Tylenol PM, Advil PM, NyQuil, a lot of these are used to help fall asleep. You don't want to take this to help fall asleep and have it worsen your restless leg syndrome, because you really won't fall asleep at that point. And then there are antipsychotics. I point out Seroquel because this, again, is used by some doctors to help people fall asleep. But some of the antipsychotics can cause restless legs to worsen. So let's move on to the actual medication treatments for restless leg syndrome. So the big one to point out is dopamine agonists. They basically work in the brain by stimulating these dopamine connections that I showed you earlier. The ones that are most commonly used are pramipexole, ropinirole, and rotigotine, which is a 24-hour patch of dopamine agonists. Levodopa or Sinemet, which is now used or it's always been used more commonly in Parkinson's disease, is actually a precursor to dopamine, which means you take the levodopa in and your body converts it to real dopamine in the brain. Most of these are FDA approved for restless leg syndrome, but I do not recommend using them, however, and this is why. So this is how in the model of the dopamine shipping port, you've got excess amounts of dopamine, the ports are malfunctioning, so you get these dopamine agonists and they attach to the shipping port and they actually deliver the message that the brain cell wants to send out. So they bypass the whole shipping system, and that's how they work. And they're highly controversial right now. The clinical consensus among most restless leg specialists is these should never be used as a first-line treatment for restless leg syndrome. Many, not all, but many restless legs experts believe they should not be used at all. I fall into this category. Not everyone is going to be in this category, but I just do not think these medications should be used at all for restless legs unless they're extenuating circumstances. Adverse effects. So let's get into why I don't like these drugs. Well, for one, they can cause side effects such as sleepiness during the day and even sleep attacks where you suddenly get drowsy suddenly without warning. If you're lucky, it causes you to be nauseated and then you stop taking it and then you don't have any side effects after that because you can't tolerate it. But one of the big ones is impulse control disorders. So what are impulse control disorders? Well, here's the list of impulse control disorders. It can include excessive gambling, shopping, eating, punding. This is like what my kids do, where they take their Legos and they take them apart and they rebuild them and then they take them apart again. Adults will actually start doing that. They'll like dismantle a doorknob and then put the doorknob back together for no reason. And this is some of the behaviors that may develop. And it can be something as the inability to control regular activities. So I had a woman who used to read 20 minutes before bedtime, and she kept taking these dopamine agonists, and all of a sudden she was reading 3-4 hours before bedtime because she had this impulse control problem. She had to read the books before bed, and it wasn't a dangerous activity, but it was something she couldn't control. So be aware of these. Here's a sampling of studies that looked at impulse control disorders. A Parkinson's study showed nearly half of the patients with Parkinson's disease developed an impulse control disorder in 5 years, because these dopamine drugs are also used in Parkinson's disease. One restless leg study had 17 out of 100 people develop develop impulse control disorder. An Austrian study showed 23 out of 58 patients. And it was 6 times more likely in this study for people with augmented restless leg syndrome. So that moves us to what is augmentation. So the biggest adverse effect is actually not these impulse control disorders, not that you're going to buy too many things on eBay or gamble away your fortune. That's actually the second worst side effect. The worst side effect is augmentation. So I've augmented this and I've turned it into red. Augmentation comes from the Latin augere, which means to increase. So augmentation means we have increased the condition beyond which it naturally would occur. We created this super bad form of the condition, and the drug itself is what does this. This cannot naturally happen this way. So what is augmentation? Well, it could be any of these things or a combination of these things, but your symptoms may come on earlier than they usually do. So instead of 10 p.m., they come on at 8 p.m. They can actually spread to other areas of the body, the torso, the arms. You may be on one dose of a medication and then you require a stronger dose to get the same effect. You're on 1 milligram for a few months and then you need 2 milligrams and then 3 milligrams. We also call this tolerance. And then there's also a faster onset of symptoms when you're resting. And there's also a paradoxical effect where you could actually take the drug and it brings on the restless legs immediately after taking it. So here's the shipping ports that I showed, and here we're going to move on to the shipping ports that in an augmented state. So initially, you're going to get more dopamine agonists because you're going to need more and more, and the shipping ports are going to start to close down. If you don't use your shipping ports, the shipping ports are going to close down. If Amazon is taking a drone and dropping the package into your house, UPS is going to close down. You're not going to need them anymore. And as you keep taking the dopamine agonist, the shipping ports keep closing down and you need more and more dopamine agonist, and the effect on the brain is less and less. So you're taking more drug and it's having less and less benefit. That's what augmentation is in a nutshell. So what to do about it? The good news is that much of it can be reversed by going off the drug. So you can actually, Amazon closes down, you need somebody to deliver your packages. Well, the shipping companies will move back in. The bad news, the brain is dependent on dopamine agonists. So you will go through withdrawal before you get better. This is true of any drug dependence or drug. If you become dependent on it, you go off of it, it's going to get worse before it gets better. The good news is many restless leg specialists, like the physicians listed on the RLS Foundation website, are skilled in managing augmentation with the help of other treatments. So it's not the end of the world either. So here are some of the numbers on augmentation that you can look at, but I want you to look particularly at the numbers: 48%, 22%, 32%, even the long-acting drug, the rotigotine patch, 13% in a 5-year span developed augmentation. We're talking a lifelong condition. Restless legs could affect you for 60 years. You don't want to be taking a drug that's going to make it worse in 5 years if you're expected to use the medication for 60 years. It just doesn't make sense to me that you would start a drug that will worsen the condition. And it seems like if anyone is on the medication long enough, it will inevitably worsen the condition. So we think that this is an inevitable problem. It's just how much you're taking and how long you've been taking it. So how should restless legs be treated if you're not going to use a dopamine agonist? Well, iron supplementation should be the front of your mind. So the forms that I like to use, ferrous bisglycinate and ferrous sulfate is actually the most common one. If you don't have anemia, if your ferritin is less than 50, you can consider something like 65 milligrams of iron. It's better to be taking it at night when the blood levels of iron are low, so your body absorbs the iron, and take it with a small pill of vitamin C to help with the absorption. Vitamin C is known as ascorbic acid. The acid from vitamin C helps to absorb the iron into your body. If you have a higher ferritin level, you can consider a lower dose, 15 to 25 milligrams. And the side effects of iron can be actually intolerable for some people. So there are no serious side effects, but it could cause a burning sensation or pain in the stomach, or you could develop constipation or hard stools. And a lot of that's because if the iron doesn't get absorbed, iron is a metal, so it's like putting a bowling ball down your intestines. It's not going to be pleasant if it doesn't get absorbed into your body. So if constipation occurs, you could consider cutting your dose in half or even alternating the days in which you take it. And then once you're on a supplement, you want to repeat your levels in 12 weeks just to see if it makes any difference, because for some people, their iron levels will not improve even with supplementation. So let's talk about iron infusion. An infusion of iron is where you'll have an IV put into your blood, like you're going to get fluids, but you get fluids that contain iron. So the advantages are that this may be the only way to get your brain levels up, particularly if your ferritin is above 75, because if your ferritin is above 75, your body's probably not going to absorb very much iron, no matter how much liver you're eating. Giving it through the IV bypasses the GI system. So if you've had bariatric surgery, this is one thing that will, sorry, my slides are having a spasm, but it'll bypass the gastrointestinal system, and it will also increase your iron levels dramatically. You can get a gram of iron in 10 minutes, where it could take you 10 months to get that much iron into your system. And there are few, if any, side effects. There are minor side effects that can occur, but really no major side effects from iron infusion. Now, what are the disadvantages? Well, this is a newer form of treatment, and newer, I mean the last 15 years or so. Insurance companies are not aware that this is a first-line treatment for restless legs, so it's very hard to get coverage for it if you don't already have another condition like anemia. It requires a doctor with access to an infusion center. So in my clinic, I see patients from all over the state of Michigan. If I don't work at their infusion center, I can't order the infusion. It's not a medication. I can't just write a prescription. And then there's a lot of myths and legends about infusion reactions. So people, even the medical centers, get worried about people reacting to iron. And all the iron that's on the market right now, there's no evidence that they cause reactions. So this is more myth and legend than reality. And then doctors, if you go to a doctor who's not familiar with iron, they may not be comfortable doing infusions. So it could also be hard to find somebody who will actually give you an iron infusion because they'll say, oh, your iron levels are normal. I don't know why you need an infusion. So what are the preferred types? I don't need to get into these in detail, but there's basically 3 major forms that can be given, 750 to 1,000 milligrams at a time. These are the ones that have the better clinical trial outcomes. The ones that are most commonly used, unfortunately, are the ones that can only be given 100 to 200 milligrams at a time, and they're just less effective. So those are the 2 to try to avoid if you can. So once you get an infusion, once you're finished with a full infusion, you want to recheck after about 8 weeks to get a steady state level for your iron. And then if your iron levels are still low, then you should repeat the iron infusion again until they are higher. So I'm just going to touch a little bit on some of the other drugs that we use for restless leg syndrome. There are other webinars that will address these in more detail. But the first line medications they're considered old seizure medications. They're not used as much for seizures anymore. They're used more for nerve pain. And the class of drugs are called alpha-2 delta ligands. So the alpha-2 delta ligands include gabapentin, gabapentin enacarbil, and pregabalin. These are the brand names that many of you have heard of. They're very commonly used. Most major clinical guidelines now for restless legs believe these are the first line drugs. If you don't consider iron is more of a supplement, not really a drug. But after iron, these are considered to be first line drugs. And they work some of them work for a short or a medium period of time. So you take them at night, they relieve your symptoms at night, they wear off by the morning. So that helps with the side effects. And the side effects can include things like dizziness or drowsiness, so be very careful. There's been a new FDA warning about the fact that these drugs can slow the breathing down somewhat, which we all knew about, but just to be aware of that, particularly if you have a breathing disorder like sleep apnea, that this could make the sleep apnea worse if you're not being treated. And then, Sir Thomas Willis. So let me get my British accent back. Sometimes, since I was advised with for a lady of quality, who in the night was hindered from sleep by reason of these spasmodic effects which came upon her only twice per week, leaving wholly the opium, was able to sleep indifferently well. So Sir Thomas Willis made these comments in the 18th century. So opiates for restless leg syndrome have been used for centuries, and opiates even themselves have been used for centuries. The ones used mostly for restless legs are methadone. Buprenorphine is becoming more in vogue. I'm actually using this one more than any other opiate now, and I know Dr. Early has also been using buprenorphine and many other members of the RLS Foundation. Oxycodone, hydrocodone can also be used for restless legs. Many restless leg syndrome experts, including myself, consider these a second-line treatment to the medications we just mentioned, that we would actually use opiates before we would use dopamine agonists. Again, that's not a consensus, but we're sort of moving in this direction. However, if you do not have augmentation, you rarely need to use opiates. There's very few patients that I would ever need to use an opiate on because they can usually be controlled by lifestyle changes and iron. Or if you need to, one of these seizure nerve pain medications. So what are the drawbacks of opiates? Well, we're on a war on opiates. So by prescribing opiates, we're working against, we're a fish swimming upstream right now. There were 47,000 opiate overdose deaths in 2017, according to the CDC. So it's a potentially very dangerous drug. There's a risk for abuse, diversion, meaning selling it to somebody else, addiction or dependence. So these are all concerns. So what are the side effects? Constipation, nausea, itching, fatigue can be side effects. And even more serious is opiates themselves also can slow down breathing. Euphoria is a problem because people can get high off of it and that can lead to addiction. It's pretty rare with methadone and it's exceedingly rare with buprenorphine. And that's why these are the #1 and I guess top drugs that are often used for restless leg syndrome. You could become impaired from opiates, so be careful while driving. And sometimes opiates can cause people to become depressed. So these are things to watch out for. I will make a point that for restless leg syndrome, we use much, much lower doses than we would for chronic pain, and the side effects are much less frequent and severe. Benzodiazepines. So these are a group of drugs called sedative hypnotics. I bring these up not because I think most people don't use them anymore, but you may encounter a doctor who may try to put you on one of these drugs. They include things like clonazepam, lorazepam, and alprazolam. A lot of these drugs are used for sleep as well, or for anxiety, but they're sedative hypnotics, meaning they make you sleepy and they paralyze your brain. So your brain slows down and you get drowsy. Not a very good thing to have in your system to be able to function well during the day. They were previously used for restless legs. I say previously because I think most people have gone away from these drugs because of the side effects. And we think that maybe they just put you to sleep rather than actually improve the symptoms. So we don't know if there's a direct effect on the symptoms of restless legs. It's just you take the drug, it knocks you out, then you don't notice you have symptoms. And then it can, as I mentioned, lead to these effects. And also benzodiazepines can cause dependence, just like a lot of other medications. So you could have bad withdrawal symptoms if you try to stop the drug suddenly, and sometimes life-threatening withdrawal symptoms like seizures. So you don't want to stop the drug if you're already on it. You want to go down with the help of your doctor. So what are some of the potential treatments that are on the horizon? Well, stimulation in the spinal cord and for the nerves or through the skin. Low-dose naltrexone is now being used. Naltrexone is an opioid blocker, and it's shown to have good effects, particularly in people with SIBO. And then dipyridamol is being studied right now, and there's some good results on that. This is a blood thinner. I would personally like to see some research on ketamine. Ketamine is a drug that's used in limited circumstances for depression, but I think it would have good properties that may help with restless legs. And then there's the holy grail for restless legs, which is figuring out exactly what the brain iron problem is and finding a drug that reverses it. Rather than just giving a lot more iron, we could actually reverse the iron transport problem. So I would like to quickly acknowledge a few people. This isn't a comprehensive list, but these are the people who have influenced me in restless legs syndrome in particular. I'd like to point out Christian Guilleminault. He was on faculty at Stanford when I trained there, and I'm glad I found this picture because this is actually a beer glass that is shaped like a leg. And so what Dr. Guilleminault is telling you is that you should not drink beer because it has gluten in it, and gluten can cause inflammation. It has lots of carbohydrates, which can cause you to gain weight. And it has alcohol, which makes restless legs worse. So he's saying no beer for restless legs. Unfortunately, Dr. Guilleminault passed away last year. It's a great blow to the sleep field. He was easily on the Mount Rushmore of sleep physicians throughout history, and he will be sorely missed. The other faculty who were the specialists in restless legs while I was at Stanford were Dr. Mark Buchführer and Julian Winkelmann, who's now back in Germany. And then members of the various groups that I belong to, including the Restless Leg Syndrome Foundation. I'd like to specifically mention Dr. Chris Early and Dr. John Winkelmann, who have been extremely helpful in developing my career. And then my fellowship alumni from Stanford, particularly Michelle Jo Nellis and Logan Schneider, who spent a lot of time shooting the breeze with me regarding brainstorming with restless legs. So I will mention that the White Noise podcast, a couple junior faculty at the University of Michigan have started a sleep medicine podcast. And episode number 4 from last year is yours truly. I promise there will be no British accent, I think, during the podcast, but this is available on all the major platforms. And I go into a little bit more detail than I did today because this was supposed to be a little more basic. But if you want to hear more about the management of restless leg syndrome, you could listen to this podcast and the episode where they interviewed me. And with that, that'll conclude my talk. So let me go over 3 points for you to remember again. Number 1, make lifestyle changes first. Don't think of medications, make lifestyle changes first, particularly to your sleep and your nutrition. Number 2, have your iron levels checked. Aggressively supplement your iron levels. And number 3, dopamine agonists may lead to dopamine agony. So be very careful if you're on these medications or you're considering going on them. So I will now allow Zibby to take us to what's left of our time, and we can answer a few questions. Hopefully I answered many of them already in my presentation.
You indeed did. So can you increase medication dosage without causing augmentation?
Well, augmentation is thought to be only due to either levodopa or Sinemet, the dopamine drug, or the dopamine agonist medications. It's not a part of the other drugs like gabapentin or Lyrica or iron. So all of those drugs you can increase, but if you're increasing a dopamine agonist, you have to ask, why do you need a dosing increase? So the fact that you need to increase your dose means your restless legs is getting worse. Therefore, it could be the drug that is augmenting the restless legs. So that's why it's sort of funny. You need more drug, but it's the drug that makes you need more drug. So that's why it's very tricky with dopamine agonists. So I wouldn't recommend dosage increases. I would recommend switching to something else and getting off the dopamine agonist, because you may actually get better if you've been on a dopamine agonist for a long time by going through the withdrawal and then having your brain reset itself, growing those receptors back, growing those shipping ports back, and then recovering. And that's what I would recommend for most of my patients, rather than increasing their dopamine agonist dose.
Does RLS ever go away, or at least lessen as you get older, or will it get worse?
So statistically, restless leg syndrome gets worse as you get older, but I think that that's not because the condition gets worse, but you just develop more health problems that cause you to have inflammation and low iron levels, and you're on more medications. So I think it's just the body is wearing out as you get older and you have more health problems. But I don't think that it should get worse as you get older specifically. The main factor I think involved is the iron itself. If you develop low iron levels, that is what's probably causing the worsening of the restless legs. And so it shouldn't necessarily get worse, and it may go away or get better if you find that you have really low iron levels and you actually supplement your iron. That could take care of the problem. I have a lot of patients who all they need is iron. They don't need any medications. They don't have very many symptoms, and then their iron levels drop below a certain number, and then they get another infusion, and then their restless legs goes away. So it is possible, particularly with the use of iron. And then if you have augmentation from dopamine agonists, going off the dopamine agonists long term can improve your symptoms as well, because remember, the drug might be causing the condition to be worse than it actually is. So by going off the drug, you might get better.
All right. Do you know of any evidence or anecdotes for using CBD or cannabis for RLS symptoms?
Sort of yes and no. So I'm not aware of any studies that have come out quite yet specifically on restless leg syndrome. I could be wrong, but I think that that is only a matter of time. Now, so we're talking about compounds that come from marijuana. Now, CBD is a cannabidiol. CBD tends to be the one that may have some effect on both sleep and restless leg syndrome. It's being studied already, particularly for insomnia and different sleep conditions. And it may not have a negative effect. The THC part of marijuana seems to have a negative effect on sleep, but it's possible that CBD could be used. Now, this is mostly what we call anecdotal evidence. So these are stories I've heard from patients, but for some patients, CBD tends to work. Unfortunately, I can't recommend CBD because there are no studies of CBD. I don't think I've really recommended anything today that hasn't at least been studied to some extent. And so to recommend something, I don't know what dose to give you. I don't know exactly what the side effects are. I don't know what the long-term effects are. So I wouldn't feel comfortable prescribing CBD oil, for example. But there have been stories, I've heard enough stories that where there's smoke, there's fire. So I think it's promising that this should be studied in restless leg syndrome in the future. I just can't use it yet. If somebody's using it, that's their prerogative. It's legal in the state of Michigan, so I do have patients who use CBD for restless legs. But right now I can't recommend it just because I don't have enough data yet. But the data will come because there is a movement to study marijuana compounds like CBD. So that's a very good question.
And we do have a webinar on our website about CBD. So if I'm going to be flying or going to an evening theater performance, what can I do or take to ensure calm legs?
So before a situation in which you have to sit still, it can be very challenging. One is to actually go for a long walk or make some behavioral change, be very active throughout the day leading up until that point. but sometimes it's pretty unavoidable. Like if you're on an 8-hour flight, what can you really do? You should get up frequently and walk around the aisleway. You can use massage. Some people get hot pads. Some people even get, there used to be a device on the market that was a vibration pad that's I think off the market now, but you can get different ways of giving stimulation to your legs, and new products should be coming out in the future. There are a few medications that can be used here or there for restless legs. Some of these nerve pain medications can be taken just before your flight. A low dose of an opiate medication can be taken before the flight, though that wouldn't be the first choice I would use. There are other medications like tramadol, which I didn't talk about, that can be used here or there. That's sort of an opiate-like medication, and it's sort of a dopamine medication. And even this drug called levodopa or Sinemet, although if you take it frequently, it will lead to augmentation, there are some patients who just take it right before their flight to get through the flight. And if you take it here or there, it's not going to actually worsen the restless legs, and it can provide relief. The one thing I'd mention, though, is to actually try whatever drug your doctor prescribes for you. I would actually try it before you actually go on the flight to make sure you tolerate the drug. You don't want to be taking your first dose of it on your airplane and having it make you extremely nauseated. So I would test that out, but it's extremely hard to, and that's part of the problem with the condition is if you're sitting still, it makes it difficult. So I recommend sitting in aisleways so you can get up and walk around, or sitting somewhere where you can stretch your legs. The economy plus, first class, if you can afford it, it may be worth it to you just so you could have some leg room.
Okay, how can we best educate our physicians about RLS?
That's an excellent question. I have been trying to figure that out because I see patients coming into my clinic day in and day out, and mind you, I see the people with the worst cases of restless legs. I don't see the patients who are doing well very often, but it blows me away how just the simple management of restless legs is completely ignored. I have people who have had restless leg syndrome for 20 years who have never had an iron level checked. I've had people on dopamine agonist doses that exceed 5 or 6 times the maximum recommended dosage for their dopamine agonist, and the doctor keeps going up and up on the dose and has no idea. So that's why I say that patients need to be their own advocate. You must be your own advocate. The Restless Leg Syndrome Foundation is an excellent resource. The articles that are on this website are so important. You can actually print them out and take them to your doctor and discuss them, because this will maybe help the doctors. Because like I said in my first few slides, many people consider this be a quote unquote minor condition, and it's not minor for most of you. And if your doctor hasn't bothered to read about it in 20 years since medical school, and they don't know anything about the condition, they remember one drug that's been used to treat the condition 20 years ago, you need to educate the doctor, or you need to find a doctor that knows something about the condition. It's one or the other, but you need to educate yourself. And I highly recommend, if you're not a member of the foundation, joining the foundation, seeing these webinars, educating yourself, and also reading the articles that are available on the website.
And I'm going to add that we have a free webinar series specifically for physicians. And if you go to rls.org/physicianed, you can print out a postcard and give it to your doctor, and they can sign up for any of these. There's a series of 12 webinars that are educating physicians. Okay, well, that's all the time we have, and we want to thank you so much for your presentation. Our next webinar will be on March 12th, featuring Dr. Christopher Early, who will discuss genetics and epigenetics and their relationship to RLS. Please visit our website to register, and thanks again for attending, and thank you for presenting, Dr. Burkowski.
Thank you very much for inviting me.
Mm-hmm.